Lecture 1, Types of Violence and its Consequences. Hello, and welcome to the first lecture of our course. Today, we'll cover several important topics. We'll begin by introducing key terms and discussing the difference between domestic violence, DV, and intimate partner violence, IPV. Then, we'll explore what abusive relationships entail, the main risk factors, and the cycle of violence. Following that, we'll delve into the various types of abuse across different age groups. In the realm of terminology surrounding abusive relationships, there's an ongoing debate among psychologists, sociologists, and others. Some advocate for viewing abuse primarily through a gender lens, emphasizing power imbalances between men and women, leading to terms like gender-based violence. Others argue for a gender-neutral approach, acknowledging that both men and women can be victims and perpetrators. A third perspective highlights the need for a nuanced approach, considering violence across the LGBTQI+ spectrum and the intersectionality of identities. For example, identities such as sex, gender, race, color, language, religion, political or other opinion, national or social origin, association with a national minority, age, disability, marital status, migrant or refugee status, or other status. For simplicity, we'll primarily use two terms, IPV, which involves current or former intimate partners, and DV, which extends to include children, elderly, or others within a household. Note that DV and IPV are subsets of the more general term gender-based violence. It's also important to distinguish between violence and abuse. Violence typically involves physical force causing harm or injury, including psychological harm. Abuse is a broader term, encompassing various harmful behaviors such as emotional, sexual, financial, digital, or social isolation. It often involves a pattern of exerting power and control over another person. DV and IPV present complex challenges in detection and measurement, often concealed within private lives due to shame and stigma. While law enforcement ensures safety in public spaces, these forms of violence may go unnoticed behind closed doors, impacting victims and families. While DV can occur in various household relationships, IPV is more narrowly focused, affecting individuals across socioeconomic and cultural backgrounds worldwide. It's a grave violation of human rights, characterized by a pattern of assaultive and coercive behaviors without consent. The European Institute for Gender Equality defines IPV as a pattern of assaultive and coercive behaviors, including physical, sexual, and psychological acts, as well as economic coercion, which adults or adolescents may use against their intimate partners without their consent. The resulting feelings of shame, fear, and helplessness lead to low levels of reporting and, subsequently, relatively few convictions. Not limited to IPV alone, DV also falls under this human rights violation. Victims of abuse need understanding, belief, and support, especially during initial contact with frontline specialists like physiotherapists, who may be the first to suspect abuse. By raising awareness and treating clients with sensitivity, physiotherapists contribute to creating a safer society for all. Tactics used in violent relationships. In different types of violent relationships, abusers employ various tactics to assert control. These tactics are outlined in the Wheel of Power and Control, also known as the Duluth Model, developed in 1982. The wheel serves to identify these tactics, formulate intervention plans, and understand patterns of violent behavior and the role of power and control. At the core of the wheel are the keywords power and control, highlighting their central role in abusive relationships. Abusers use intimidation, humiliation, and coercion to instill fear and enforce compliance. The inner portion of the wheel represents psychological tactics, while the outer ring depicts physical and sexual violence, often reinforcing subtler methods. In domestic violence, the impact of violence extends beyond the victim to observers, especially children. Physical violence includes acts like hitting and pushing, often accompanied by sexual violence, perpetrating trauma across generations. The wheel outlines 8 distinct tactics. Intimidation generates fear through past violence or aggressive behavior. Emotional abuse diminishes the victim's self-worth through constant criticism and belittling. The ultimate goal is making them believe that they are unworthy and incapable of survival without the abuser. Isolation ensures control by cutting off the victim from support networks. By isolating the victim from family and friends, the abuser aims to prevent the influence of external ideas and maintain control. Minimizing, denying, and blaming is another tactic employed frequently by an abuser. When things do not go as desired, they shift blame onto the victim or deny responsibility, leading the victim to internalize self-blame. Over time, the victim adopts the abuser's way of thinking, and may even blame themselves preemptively. For example, if I had folded his shirts correctly, he wouldn't have hit me. This tactic reinforces the abuser's dominance and submission of the victim. The use of children is a tactic employed by the abuser to manipulate the victim, exploiting their concern for their children's well-being. Male privilege underlies all abusive behavior, asserting superiority and entitlement over women. The abuser fundamentally views women as inferior and asserts superiority and ownership within the household. Abusive men may exhibit excellent negotiation skills in other contexts, such as with co-workers or their boss, but they refuse to negotiate with their partner, viewing her as beneath them and subject to their authority. Please keep in mind that the Duluth model, while informative, focuses primarily on heterosexual relationships and does not address other partnership dynamics. Controlling finances limits the victim's autonomy and ability to leave. Lastly, coercion and threats constitute the final tactic employed by the abuser. It compels compliance through manipulation and intimidation. When coercion fails, threats may be employed to maintain control. The cycle of abuse. Experiencing violence once increases the likelihood of future victimization. Long-term violent relationships follow a cyclic pattern, consisting of 3 recurring phases, each varying in intensity and duration. Violence may escalate over time. Phase 1. Tension building. Communication is tense, marked by emotional abuse, humiliation, and intimidation. This phase, which can last weeks, months, or years, involves incidents like jealousy and shouting. Victims may feel constantly criticized and blame themselves, while the aggressor seeks increased control, causing emotional distance. Phase 2. Acute violence. The shortest phase, characterized by physical, psychological, or sexual aggression resulting in injuries. Victims feel scared, withdrawn, and powerless, often waiting days before seeking help. Phase 3. Reconciliation, or honeymoon. The aggressor seeks forgiveness using manipulative tactics to maintain the relationship. Gifts, promises to change, and quality time together reduce tension, temporarily fostering hope for improvement. Both parties may deny or minimize the incident during positive moments, but this honeymoon phase is not genuine. Its purpose is to prevent the victim from leaving, ending when minor incidents recur. With each cycle, peace phases shorten. Coercive control is a consistent feature, complicating efforts to leave such relationships. Risk factors. Various factors contribute to the use of violence, including quality of family relationships, frequent quarrels and unresolved issues between partners, extreme jealousy, dissatisfaction with marriage or cohabitation, mistrust, and power imbalances where one partner dominates and controls the other. Parent-child relationships and parenting style, lack of parenting skills, emotionally cold, indifferent, or hostile parent-child interactions, physical punishment, dissatisfaction with the parental role, authoritarian parenting style with strict discipline and limited acceptance of the child's opinions or needs. Character traits, emotional states, and social competence. Lack of empathy and warmth, emotional instability, quick to anger or get upset, dominant and authoritarian communication style, strong sense of ownership, low self-esteem, communication difficulties, tendency to control or check constantly, misunderstanding or distorting others' speech or behavior, and lack of coping skills in stressful situations. Adult psychopathological disorders: personality disorders, neuroticism, depression, suicidal tendencies, and problematic use of substances like alcohol or drugs. Personal experiences: childhood abuse, witnessing parental violence, and poor parenting experiences in childhood. There are additional demographic characteristics that increase the risk of violence. For example, pregnancy, which may trigger or exacerbate violence against women. Furthermore, people with disabilities are at increased risk of violence. IPV and children. Violence can deeply impact a person's life, especially when experienced during childhood. In cases of intimate partner violence, or IPV, involving couples with children, even if the violence isn't directly aimed at the child, they are significantly affected. Here are some potential effects. Emotional and psychological consequences: fear, anxiety, depression, and post-traumatic stress disorder, or PTSD, a sense of helplessness and compromised feelings of safety and security, behavioral issues: aggression, defiance, impulsivity, and hyperactivity, self-regulation difficulties, withdrawal, or engaging in risky behaviors. Poor mental health: increased risk of anxiety, depression, suicidal ideation, and self-harm, which may persist into adulthood. Interpersonal difficulties: challenges in forming and maintaining healthy relationships, including trust issues and emotional regulation. Academic challenges: difficulty concentrating, learning difficulties, lower cognitive abilities, and disruptions in school attendance. Physical health issues: stress-related symptoms like headaches, stomach aches, fatigue, and increased risk of chronic health conditions. Cycle of violence: increased likelihood of repeating patterns of violence in adulthood, perpetuating the cycle across generations. Long-term consequences: unresolved trauma and exposure to violence in childhood can have long-term effects in adulthood. It may contribute to mental health disorders, substance abuse, relationship difficulties, and a higher risk of re-victimization or perpetration of violence. It is important to note that not all children exposed to IPV will experience these outcomes, as individual resilience, protective factors, and support systems can diminish any impact. Nonetheless, early intervention, counseling, and access to supportive services can help mitigate negative effects and promote healing and healthy development for children who have witnessed IPV. Forms of IPV exposure in children: direct physical presence during violent incidents, auditory exposure to shouting or physical altercations, visual exposure to the aftermath of violent incidents, verbal disclosure or discussion of violence by parents, involvement in conflicts between parents, online or digital exposure to abusive content, emotional and psychological exposure to verbal threats or degradation, witnessing stalking or harassment, observing manipulative behavior or gaslighting, and witnessing interventions by authorities. Signs of IPV exposure in children: unexplained or frequent injuries, sudden changes in behavior or mood, regression to younger behaviors, decline in school performance or attendance issues, sleep disturbances like nightmares, fear or avoidance of a parent, excessive concern for a parent's well-being, displaying age-inappropriate knowledge, emotional dependency on an adult outside the family, delay in seeking medical care for injuries, inconsistent stories or explanations, direct disclosure of violence experiences, signs of parental coercion or pressure, identification of family risk factors, and consistent discussion or depiction of adult conflicts by the child. Violence against older people. Violence against older individuals often remains unnoticed or unreported, with many suffering silently due to shame or fear of consequences. By openly discussing elder abuse, we raise awareness, challenge ageist attitudes, and foster a society that values and protects the rights and well-being of all its members. Elder abuse, a form of domestic violence, is a widespread global issue, with reported prevalence rates varying significantly. However, studies suggest significant underreporting, with only a fraction of cases being reported. The World Health Organization estimates that approximately 1 in 6 individuals aged 60 and above have experienced some form of abuse in community settings within the past year. With aging populations on the rise, elder abuse is projected to increase. Defined by Action on Elder Abuse and adopted by the World Health Organization, elder abuse involves acts or omissions within a relationship of trust, resulting in harm or distress to an older person. It transcends socioeconomic status, religion, or ethnicity, with key factors including power imbalances, dependency, and isolation. Violence against the elderly often leads to loneliness, as victims may have their other relationships severed. Abuse tends to escalate after children leave home, leaving older individuals isolated and fearful of bringing grandchildren into a violent environment. Underreporting of elder abuse persists due to victims' shame, dependence on abusers, fear of retaliation, illness, and uncertainty about reporting procedures. Elder abuse has severe consequences, affecting both physical and mental well-being. Older individuals, physically weaker, suffer more significant harm from abuse, leading to prolonged health effects and exacerbating chronic diseases. Mental health declines with increased depression, stress, and PTSD risk. Prolonged exposure to violence may even lead to suicide or self-harm. It's imperative to address elder abuse, providing support, resources, and intervention to safeguard the well-being of older individuals. Types of elder abuse. In this section of the lecture, we'll discuss the main types of elder abuse and how physiotherapists can recognize signs of abuse. You can identify these signs through direct observation or by conversing with your client. However, it's essential to exercise caution, as some signs may be indicative of normal age-related changes. It's often more reliable to observe behavioral changes over multiple sessions and engage in gentle conversations, rather than jumping to immediate conclusions. That said, there are instances where your empathetic reaction, supported by observation, is accurate in identifying abuse. Physical violence. The use of physical force against an older person, which can cause bodily harm, permanent impairment, or physical pain. It can take the following forms: scratching, biting, slapping, burning, throwing things at a person, using weapons or other objects to inflict pain, pushing, kicking, choking or strangling, force feeding or denying food, and physically restraining a person. Signs of physical violence may include carer or relative is overly protective or controlling, tells conflicting stories, delays in seeking care or reporting an injury, does not leave the older person unattended, older person described as accident-prone or having a history of sustaining injuries, repeated accidents or emergency department presentation and frequent falls, visible bruises, wounds, abrasions, contusions, hematomas, injuries in different stages of healing, broken bones, sprains or dislocations, welts, rashes, blisters, burns, lacerations, swelling, signs of being restrained, weight loss, hair loss, poor hygiene, physical pain, soreness that does not respond to treatment, cringing or acting fearful, agitation, catatonia, frequent requests for care or treatment for minor conditions, unexplained anger, fear, or shutting down behavior around the carer or relative, and oversedation or grogginess. Psychological or emotional violence. Systematic, non-physical actions intended to inflict mental pain, anguish, and suffering on an older person. It can take the following forms: emotional manipulation or other cruel behavior, denying access to services, religious and/or cultural events, forcing a person to participate in and follow religious rules and customs, harassment, stalking, nonverbal communication hints such as facial expressions and body gestures meant to intimidate, degrade, manipulate, or insult, verbal intimidation, shouting, insults, scolding, humiliation, threats, denigration, controlling behavior, and abandonment. Signs of emotional violence may include self-reported feelings of helplessness, shame, or powerlessness, loss of interest in self or environment, lack of eye contact with a practitioner, carer, or another person, nervousness or other changes in behavior around a carer or another person, display of signs of trauma, for example, rocking back and forth, depression, sadness, or tearfulness, changes in self-esteem, lack of confidence, fearfulness, unusual passivity or anger, agitation, disorientation, isolation, withdrawal, apathy, reluctance to talk openly, self-reported insomnia or sleep deprivation, and problematic substance abuse. Financial violence: the illegal or improper exploitation or use of funds or other resources of the older person. It can take the following forms: controlling the use of money and property belonging to an older person, theft, use of coercion or fraud to try to obtain an older person's money or possessions, illegal or improper use of an older person's money, property, or assets, the exploitation of or pressure in connection with wills, property, or inheritance, and fraud and internet scams. Signs of financial violence may include expresses concern over money to cover their basic needs, speaks about funds missing from their accounts, confusion if mentioning assets, property, and income, contends that furniture, jewelry, credit cards, documents, or other items are missing, voices worries over unpaid bills or overdue rent that they themselves should be able to afford or that someone else is expected to pay. Sexual violence: a perpetrator engages in sexual behavior towards an older individual, including physical contact of a sexual nature without their consent. It can take the following forms: unwanted sexual contact, for example, inappropriate touching, sexualized kissing, forcing an older person to watch sexual acts or pornographic material, forcing an older person to undress against their will, coerced nudity, cleaning or treating an older person's genital area roughly or inappropriately, sexual assault and battery, forcing an older person to perform a sexual act, forced intercourse or rape, explicitly sexual photography, and sexual remarks or suggestions. Signs of sexual violence may include frequent urinary tract infections, unexplained venereal disease, fear of being touched, increased sexual or aggressive behavior, depression, anxiety, nervousness, withdrawal, insomnia, nightmares, anxiety or excessive fear around a carer, increased interest in sexual matter, unexplained incontinence, bladder or bowel, difficulty walking or sitting, or pain when toileting, bleeding, bruising, abrasions, infection, tenderness of the anogenital area, thighs, and breasts, problematic substance abuse. Neglect: a failure by responsible persons to satisfy the essential basic needs of an older person. It can take the following forms: the person is abandoned, left unattended for long periods, or locked in the house alone. Inadequate or inappropriate use of medication. The person is over-sedated in the middle of the day. The person is not provided with necessary aids, for example, glasses, hearing, or walking aids. Immobility, the person stays in bed almost all the time. Inadequate food and drink. Isolation, lack of mental, physical, and social contacts. Lack of clean, appropriate clothing. Restraints, the person is tied up to the chair or bed. Inadequate medical or dental care. Exposure to unsafe, unhealthy, or unsanitary conditions. Signs of neglect may include pain, discomfort, multiple large bed sores, unexplained weight loss, malnutrition, dehydration, constipation, poor hygiene, unkempt appearance, an older person is dirty, smells strongly of urine, poor or nervous interactions between an older person and carers or family, signs of withdrawal, depression, passivity, absence of required assistive technologies, lack of concern on the part of carers or family, or overly attentive behavior in the presence of outsiders. Institutional abuse. Vulnerable people are mistreated by the system that is designed to give them care and safeguard them from abuse. The term institution covers a wide range of health and social care settings, as well as any setting where service users interact with professionals outside their own home. For example, hospitals, nursing and care homes, daycare and respite care, care provided by the voluntary sector, and hospice care. It can take the following forms: restraints, controlling the behavior of older persons, mechanical restraints, physical restraints, chemical restraints, physical violence, rough treatment or assault, psychological abuse, verbal abuse, ignoring the wishes or will of a resident, isolating, belittling, sexual abuse, financial exploitation, neglect of care and assistance, and violation of rights. Signs of institutional abuse may include a strict or inflexible routine, a lack of privacy, dignity, and respect for people as individuals, little choice offered for food, drink, dress, or activities, difficulty engaging with proprietors, managers, or staff, an unsafe, unhygienic, or overcrowded environment, poor standards of care, too few staff to meet residents' needs, absence of individual care plans, over-medication and/or unsuitable restraint used to manage behavior, cuts, bruises, pressure sores, or indentation marks from slings or pads being left on too long or when they shouldn't be. Visits or the involvement of friends and relatives are discouraged. Distress, depression, extreme boredom, and decline in appetite. Challenges when working with elderly victims. When working with elderly victims, you might face different challenges. In this section, we will outline responses you may take. If an older person does not want help, avoid pressuring them. Explain why you suspect violence. Ask what they want to do instead of telling them what to do. Document your concerns and evidence. Reassure them that you respect their wishes but offer options. Ask if you can revisit the topic later. If an older person is hostile or abusive, acknowledge their feelings. Stay calm and ensure safety if they lack understanding. And offer support and referrals without pressure. If an older person wants to leave as soon as possible, collect their contact details and caregivers' contacts. Offer follow-up care options with consent, and assess their safety. If an older person is seriously ill or hallucinating, give them time to recover, refer to follow-up care with consent, consider past violence experiences. If language is a barrier, use an official interpreter, avoid using relatives or friends. For older women, ensure a female interpreter. If an older person is accompanied by a spouse or partner or child, remember that the accompanying person can be the abuser. An older person has the right to be examined in private. Explain this to the accompanying person and do not leave the decision to the older person. Arrange a separate appointment if necessary. If an accompanying person is required for cultural reasons, try to find a trustworthy person with the older person's consent. If an older person mentions their partner's jealousy, recognize it might relate to intimate partner violence. Keep in mind the difference between violent jealousy and normal jealousy, as well as the difference between disagreement and violence. Ask them if the behavior of their spouse or partner has changed recently, and remember that sometimes dementia can be the cause of violent and/or jealous behavior. If the answer is yes, refer them to the appropriate services. If an older person talks about alcohol consumption in their family, keep in mind that alcohol-related behavior can mask violence in the family, and that alcohol abuse increases the risk of violence. If alcohol abuse is caused by illness, for example, dementia, refer them to the appropriate services. If an older person talks about mental health problems and stress in their family, an older person may use mental health problems and/or stress to understate or justify violence. Explain to them the connection between mental health problems and stress and violence, and refer them to the appropriate services. Depending on the situation, additional actions may include referring an older person or their caregiver to the appropriate support services, for example, caregiver services, women's services, social services, referring an older person or their caregiver to the relevant specialist for medical examination or treatment, for example, geriatric, gynecological, mental health, substance abuse, arranging for an older person to stay in emergency accommodation, for example, women's shelters or support centers, temporary accommodation services provided by local governments, etc., reporting the case to police in cases of imminent danger, severe physical injuries, or risk of lethality. Please remember, privacy and dignity of older people should be respected at all times. Older people should be involved in making decisions about their lives as much as possible. An older person's mental capacity can be temporarily affected by stress, anxiety, medication, illness or injury, and therefore lack of capacity does not necessarily indicate dementia. However, if they seem unable to make a decision, a formal assessment of mental capacity might be required. Older people's freedom of choice must be respected, and mentally competent individuals have the right to refuse help. For example, if an older person is competent and chooses to stay with an abuser, this should be accepted. In such cases, specific professionals should assess the older person's safety and give them the necessary safety information. Physiotherapists must know the legal requirements related to reporting violence. If there is a high risk to the older person's physical safety or life, they must consult the police and/or social workers and take the appropriate actions, even if this goes against the older person's wishes. In case a crime is suspected or has been committed, physiotherapy professionals must act according to the laws of their country. Older people's right to confidentiality must be respected, but should not be a barrier to taking action. Cultural differences, religious beliefs, gender, older people's abilities, and resources should be considered when communicating with older people and their caregivers. Violence and addictions. Intimate partner violence often intersects with substance abuse, forming a complex relationship. While not all IPV victims use substances, and not all substance users are perpetrators of IPV, there's a notable correlation between the two. Problematic substance use, or PSU, is a significant health and social concern. In Europe, an estimated 96 million adults aged 15 to 64, or 29% of the population, experimented with illicit drugs by 2019. Alcohol, too, poses challenges, with heavy drinking reported by almost 1 in 5 Europeans. PSU development is influenced by various factors, including biology, gender, ethnicity, and social environment. Early substance use experimentation is a high risk factor, with some progressing to addiction, characterized by compulsive substance use despite adverse consequences. Research shows PSU prevalence among IPV survivors and vice versa. For instance, DV shelter residents often have substance use issues. The relationship varies by country and substance. Victims may turn to substances to cope with trauma, leading to addiction. Recognizing the link between IPV and PSU is vital for health professionals. The complex relationship creates challenges in determining causality. Some perpetrators use substances to control their partners, exacerbating the cycle. Substance use can impair a victim's judgment of danger and provide a false sense of power. IPV survivors may fear disclosing PSU due to legal or child welfare concerns, further isolating them. Attempts to quit substance use may face resistance from controlling partners, leading to relapse or escalated violence. Among the forms and signs of DV or IPV that often coincide with PSU are the following. Forms: physical violence, substance abuse can worsen injuries. Psychological abuse, substances may be used for manipulation. Financial issues, substance costs can strain relationships. Self-medication, victims may use substances to cope. Legal issues, IPV and substance abuse can lead to legal consequences. Some of the signs may be as follows: continuous covering of arms, legs, and face, reluctance to remove sunglasses or hats, avoidance of activities, a sudden increase in the amount of makeup or concealer applied, reluctance to make eye contact, constantly looking down, extreme nervousness and flinching, especially around others, increasing withdrawal and silence, frequent unexplained injuries such as bruises, cuts, or broken bones, sudden and drastic changes in behavior or mood, such as extreme irritability, paranoia, or aggression. Specific forms of gender-based violence. Gender-based violence encompasses various forms of abuse and harm inflicted upon individuals due to their gender. This includes physical violence, emotional abuse, sexual assault, and economic coercion, among others. In addition to these common types, gender-based violence also includes two specific forms to note: sexual strangulation and female genital mutilation, or FGM. These distinct types highlight the multifaceted nature of gender-based violence and the need for appropriate referrals for victims and survivors. Sexual strangulation can take the following forms: physical strangulation, applying pressure to the victim's neck, obstructing airflow; choking, blocking the victim's airway by compressing the throat; covering the mouth and nose, making it difficult to breathe; strangulation during sexual assault, combining sexual violence with physical strangulation. Signs of sexual strangulation may include bruising, petechiae, small red or purple spots on the skin, or marks on the neck and throat area; difficulty breathing, swallowing, or speaking; a hoarse voice, or complaints of a sore throat. Victims may cough, gag, or struggle to catch their breath; neck pain, stiffness, or discomfort; temporary memory loss or confusion due to reduced oxygen supply to the brain; fear, anxiety, PTSD symptoms, or depression. Female genital mutilation can take the following forms: clitoridectomy, partial or total removal of the clitoris; excision, partial or complete removal of the clitoris and labia minora; infibulation, extreme form involving removal of the clitoris and labia minora, followed by sewing together of the labia majora. Some signs may include urinary and fecal incontinence, damage to nerves and muscles responsible for bowel control; psychological distress, including anxiety, depression, PTSD, and other emotional challenges; severe pain during sexual intercourse; frequent or irregular bleeding during menstruation or urination; persistent pain, discomfort, or infections in the genital area. That concludes today's lecture. Thank you for watching. In the next lecture, we will continue discussing signs of abuse and how to identify them. Remember to complete the weekly assignment to progress to the next module of the course. See you in the next lecture. Goodbye.